This is a service delivery model, and I'm Chantal McLeave.
I'm Becca Anderson.
And I'm Madison Titus.
The creator and date of the service delivery model was Glenn E. Van Andel, and he created it in 1998.
Behind Van Andel's service delivery model are based on John Nullinger's social psychological leisure theory, and the developmental theory was also a factor.
The goal of the service delivery model is to empower the client to achieve her or his desired goals and optimally experience a sense of fulfillment, satisfaction, optimal level of independence, mastery, and well-being to ultimately increase the quality of life. In the service delivery model, there are four service areas. The first is diagnosis or assessment component. The second is treatment or rehabilitation component. The third is education component, and the fourth is a prevention or health promotion component. In these four areas of service, as you can see, starting with diagnosis needs assessment at the top left of the diagram, the diagnosis and assessment component focuses on determining the strengths, limitations, and abilities of the participant in reaching goals. Some of the leisure activities may be used, but most specialists use structured interviews, agency-generated assessments, or standardized assessment tools to determine strengths or limitations. Often this is what takes place with initial assessment and determining the goals that would be most appropriate for progression. An example of this would be if someone has a difficulty speaking, then finding activities to help him or her trust and communicate without feelings of self-harm would be an example. Second area of treatment and rehabilitation, as you're moving to the left on the diagram, or to the right on the diagram, focuses on the remediation of deficits in health or functional limitations in the participant. This uses for treatment vary, including expressive media, athletic activities, and walks in the woods. And an example of that would be with the same case of a speaking impediment, finding activities that make them comfortable or help them open up in order to trust others would be a good example of some sort of treatment or rehabilitation component. The third, moving again to the right, of the education component focuses on assisting the participant in developing skills, attitudes, and values that will allow them to function in society and improve health and achieve a higher quality of life. This will help them develop skills that they will be able to use to cope with the current issue that they have at that time. An example of this would be to teach them skills as to how they can control their environment and to teach sports or activities to help them express themselves appropriately, rather in different situations. The fourth component of prevention and health promotion focuses on attitudes that protect or promote healthy lifestyles. And an example of that would be teaching behaviors such as sports to promote the physical health component and preventing their return to previous dysfunctional behaviors. As the client attitudes improves, they gain more self-confidence and they are better able to utilize the nature of the services and thus improving the overall quality of life, as is seen in this diagram. And as we mentioned in the previous slide, the outcome of the service delivery model is to reduce the deficits to move toward a higher quality of life of the participants or clients. The definition of therapeutic recreation, as seen by the service delivery model, is to facilitate integrative experiences, most often through play and recreation, which enhance clients' quality of life through both functional and fulfilling means to ultimately assist client in achieving his or her optimal level of independence and restoring a sense of wholeness to the person.
Unique aspects or attributes of the service delivery model are that the model compresses multiple views into one practice. It also has the ability to facilitate integrative experiences, most frequently through play and recreation. Van Andel's articulation is unique in that it displays Nullinger's interpretation of leisure within the model. The model does not provide parameters that limit or define TR of practice. This allows more flexibility and freedom in both client and TR specialists in the delivery of service. Then finally, the last attribute listed is that although each of these components have been described as a separate construct, it is difficult to draw clear distinctions between them, and several may function simultaneously.
One of the strengths of the service delivery model is the fact that it's quite flexible depending on the needs of the participant. One of our other strengths that we found was there's a lot of variability in the focus of services. So depending on the setting and where you want the emphasis to be, this can be placed more strongly, for example, on leisure experiences or on intervention services. And this allows the focus to be more on the participant as opposed to what the service provider is wanting. And it provides opportunities and experiences tailored to their specific needs. And this makes it really easy for therapeutic recreational specialists to use, as it creates less, restrictions in what they're able to do for programs and for facilitating. One of the weaknesses that we found that the service delivery model has is the deficits approach. So when the service model focuses on the reduction of deficits, this approach is proven to not be as effective as the strengths approach, as it focuses more on the negative aspects instead of focusing on the positive strengths of a person. Another weakness we found was that it's continuum-based. The fact that this is a continuum approach is one of the biggest weaknesses, in that participants can get caught in the continuum if they're not able to earn their readiness and move to the next level of services and essentially the next level of control of their lives. And this creates a lack of self-determination. Another pitfall of this is the professional has control of control. Or in other words, the therapeutic recreational specialist decides when the participant is ready for more control in his or her life. And the last pitfall of the continuum approach is the assumption that change must happen in order for the participant to move up the continuum towards more freedom. The service delivery model would have been more strengthened if Van Andel's presentation of the theoretical and philosophical foundations for his model were more fully incorporated in the enormous body of literature and perspectives that deal specifically with establishing and maintaining helping relationships and facilitating client change. And these are the sources that we used for our service delivery model research, just the textbook and the articles that were provided online.